Okay, so I'll ask council members or committee members to take their seats. All right, I'll call this committee meeting to order and ask that everyone please turn their electronic devices to silent or vibrate mode, and please ensure that you are properly signed into the system. And then I'll now ask if there are any disclosures of pecuniary interest. Okay, seeing none, we have one presentation this morning. So it is the Upstream Project, a youth homelessness prevention initiative. And I will ask Ann Harrison from the DSBN, who is a student achievement leader, to come up and present. Sorry? Oh, I'm sorry, and I forgot, and Michael Lethby, Executive Director of RAFT. Sorry, I apologize. I had my little sticky note here and I was just going with that. So whenever you're ready.
Good afternoon, everyone. Hopefully the technology works, right? We're here to present the Upstream project and to give you some more information on a pilot that we ran earlier this year. So the Upstream project. What is the best way that we have to address youth homelessness is really working to prevent it in the first place. And so what is the Upstream project? The Upstream project is a take, an adoption in Canada of an Australian project that occurred. The Australian government started identifying and working to eradicate youth homelessness back in the 90s. And they did it through two streams. One was program interventions, but they also critically, with every program intervention, they also attached an evaluative component through their universities. So these two worked in tandem, so there's a constant feedback between the program operation and then the evaluation and feedback, which then fed the innovation in the program. Out of that came their Upstream, which is the Geelong project, which is a region in Australia similar to Niagara, actually. The key critical piece of that work, both the program and the evaluation, was the critical roles that schools play in our ability to end and prevent youth homelessness. So, why schools? Almost every young person who comes into contact with our shelter has been in high school immediately prior to their homelessness. And so that is what's been found in Australia, and when we looked at our research at the RAFT, that is almost 100% true of the youth who enter our shelter. They were in high school immediately prior to their homelessness. So that's for the ages 16 to 19. And what's the goals of our program? So the goal is to transform the way that we respond to youth homelessness by shifting the focus from the crisis prevention, which has been the predominant model up till now, to a prevention model. And very much this is familiar territory to anyone that's worked in health. This is the model to move from not addressing it when people are walking through the door injured, but really getting upstream of the project. We want to reduce the number of young people who are experiencing homeless. We want to support the Canadian communities that are planning on also launching this. Since we've had our screener, the work that we did back in April, I've had contact with Calgary, Hamilton, Ottawa, and York region have all contacted me on our experience because they're now all looking to continue and adapt and use the same model that we're using. We want to reduce high school dropout rates, family breakdown, and the involvement in crime, all directly linked to street involvement. And ultimately, what will that do? We want to significantly increase school engagement, graduation rates, and access to safe and stable housing. I think we can all agree that if our students graduate, the chances are they're going to have a higher income than if they don't graduate, which directly leads to their ability to own and live in a house. So how is this done? The Upstream project, a critical tool, is the population screener. And so it's based on a number of different indexes and questionnaires. Importantly, there's 12 questions measuring self-esteem, resiliency, psychological distress, self-efficacy, connectedness to home, and connectedness to school and community. The survey itself contains 9 standardized assessment tools, and this is really the heart of what was designed in Australia and that we've now adopted here. This is the process that the student goes through and the project goes through. So we have the we have the actual screener for students. The screener, then the data is analyzed. In tandem, we have a follow-up with the absent students, so the students that weren't able to participate in the screener. And also, it's sort of a dual, so it's not only just the screener providing information, but we're actually working with the people on the ground who meet the students every day, so the teachers and other officials, so that they have input into at-risk. This creates the categories, and we have 3 tiers of at-risk based on this. So the first tier is sort of temporary. This is our largest. These are youth that typically have 1 at-risk factor of the 5. Tier 2 is the next group, and they require some moderate supports, and they would show 2 to 3 tiers of risk. And finally, tier 3 is a student who then shows risk across the board, is the most at risk, and is also the smallest percentage, but would require the most service. And so, Anne, I think.
Sure. So we work closely at the District School Board of Niagara with the RAFT to support all of our students, and it's primarily been interventions once we're aware of the fact that a student is facing potential homelessness. So we were excited to work with the RAFT to do this upstream project. We had multiple meetings to talk about what this would look like and to design and implement the survey tool and have some input into that, which we appreciated. We then talked to our senior team and selected a pilot site, a school with a population of students that we felt would be manageable to pilot this in, and with support of the full in-school student success team at that school. We then did a process where there was an opt-out consent form. So we had a situation where students could opt out of being screening, but if they didn't return that form, they were part of the process. We had 11 parents or students who returned that form and were not in the survey that day. And then members of the RAFT and their support team presented at a staff meeting to make sure all of our staff at our pilot school were aware of the project, were understanding of what its goals were, and understood how the implementation of screening and the process would work the following week. Just click in. Then we had our screener day was April 26th of this past spring. We chose to have a full assembly. We had actually a grade 9-10 assembly and then a grade 11-12 assembly. And our goal was to introduce to the students all of the supports that were in place for them. In other words, all the community groups that were there to support them with any kind of challenges or community resources that they might need to reach out to, as well as the school staff. So we had the presence of the RAFT there, we had the Canadian Mental Health Association there, we had Community Addiction Services of Niagara, and the goal was to show that there were wraparound supports for all of them. The students left the assembly, went back to their homeroom class, and the teachers then distributed the survey. They completed the surveys, and they were returned to a central area in the school where we had RAFT staff really quickly look at the answer to question number 7D. That was the only one that we wanted to respond to immediately on that day because it was a specific question, do you feel safe at home? And we had numerous RAFT staff present in the hallways so that the kids knew that there was somebody there. The teachers knew they could release the student to the hallway if necessary. But we met immediately, or the RAFT staff met immediately that day with 25 students who'd indicated yes to, or sorry, do you feel safe at home? They'd indicated no, sorry. So we had RAFT staff meet with them immediately because we didn't want them going home that day without supports in place. That resulted in 1 intake to the Youth Reconnect program and 1 intake to Eternal Roots. We want to move on. After that, we then did a follow-up of the survey results, and we met with the in-school student success team so that the RAFT staff came, shared all the data with us, and we reviewed all of the results. And then do you want to talk about the further follow-up that happened as a result of looking at the data from that? Or do you want me to share that?
Oh, yeah.
I can do that. In the end, we had 25 students were identified, 21 were met with by RAFT staff, and we ended up with 2 intakes to the Youth Reconnect program. We also sort of triaged the results and indicated there were a number of students in the building that we connected with a caring adult within the building to make sure that somebody on the staff at the pilot school connected with that individual to make sure that they understood who was their contact, and we did some monitoring of that. Next one's you.
And I believe in total, we had about 80 students
80 students again.
that were identified at some level of risk, so either in tier 1s, 2, or 3. And that's at the meeting that Ann was referencing. That's where we were able to decide who was the best contact and what level of support those students required. So what we've learned, so the Geelong project predicted that there would be a 50% increase in the number of students required for service. And the main way that, and the way that we currently use for our Reconnect program prior to Upstream and the survey tool, is teachers really identify a student at risk because there's been a change in behavior, a change in attendance, or a change in grade. And so that's also what the Geelong project research indicated. And then further to that, their research indicated that that is only true for about 50% of the students. So there's only a change in behavior, change in grade, or a change in attendance for 50% of the at-risk students. The other 50, they just end up homeless without any indication before. So our direct experience then is we had 4 students access our service due to the survey results. Now these are 4 students that hadn't already accessed. We had no relationship with these students prior to conducting the survey, which is double the amount of students we were currently working with. So we already had 4 students in that school that we were aware of using our traditional means, and then we had this increase of 4. So in fact, we've actually more than doubled the Geelong results. Now, this is one sample site, so I expect if we did a full population survey, we'd probably become more in line with Geelong, but clearly it more than showed that the research and the data was correct. Ann?
Yeah, one of the things we did learn is that on the same day that we did the survey, we surveyed the students to ask them who their supports were within the school from the in-school student success team. And we quickly learned that some of the students didn't know all the supports that were already in the school. So our lesson is the next time we do an assembly, we want to make sure that we do a more focused look at what are the supports you have in the school and how can those individuals help. Is that you? Or no, it can be. And the other was that one of the things that came through was how students cope with stress and resiliency was something that came up as a flag that is a focus work for ongoing efforts that we need to do in terms of how can we benefit from programs designed to support them in dealing with stress and building their resiliency.
And I think just an observation that I made, so the number tier 1, so where students represent 1 level of risk, it was in that resiliency category. Mm-hmm. And I think for a lot of the teachers that were present at the review, this is where some of the big surprises that, no, I never would have suspected that this would be a student that might have a risk factor. So that was an interesting finding for us, and I think a way of sort of reimagining how we're delivering service and making sure that we're delivering service in the most effective way. Also, one thing that was very interesting, question number 7D that we referenced earlier, where the question is, are you safe? Do you feel safe at home? That would, if anyone answered anything other than yes, we met with them that day, so we met with 25 students that day. When we actually met with those students and started asking them what was the cause of the thing that was making them unsafe, the majority of the students actually, they identified personal safety with family safety. And so if there was a food crisis in the home or electricity had been turned off, so it wasn't actually their own, and this is very interesting because the way we, especially as working in sort of a public service liberal environment, we're always thinking of the individual and as an individual, but really the students are seeing individualness in their family. Like there's no distinction between risk to family and risk to self. It's really the same thing for the student, which is very interesting, especially as an adult. This isn't normally how we would engage and isn't something that we anticipated in that question. We were talking very directly about your own personal safety as an individual, but the students interpreted it as their safety was directly linked to their family safety. And then if we consider that almost 80% of youth who identify the reason for their homelessness being conflict at home, and so the fact that they're homeless because there's been trauma to the family, it really speaks to the work we need to do around the mental health, because by leaving home, they're actually, not only are they physically leaving family, but they're seeing it as an actual trauma to themselves physically, which I think is a really interesting finding and not something that we anticipated through this question. And then finally, more community supports. At the assembly, we had a number of supports, but there was definitely room, as the survey provided, that we could see where other supports, other people, other groups would be worthwhile having there because of how the students answered some of the questions. And then next steps.
So currently, we're looking at returning to our first pilot school and doing the survey again. We have a new cohort of students since the spring, additional students in other grades. We'd also like to revisit. We know the Geelong project revisited and went back to the same students and asked them questions again to delve deeper. And we're also looking at potentially expanding it to another school within our board.
We are currently in contact with the Niagara Catholic District School Board, also about introducing the pilot into their system. That's ongoing. And then ultimately, we didn't spend a lot of time, it's in your notes, you can refer to the number of staff hours, and that's just on the RAF side. Anne could speak to the number of hours that was put on by her team. But clearly there's a resource component, infrastructure component that we built in, especially if we were looking to expand this, as they have in Australia across the entire region, which would be every school board, every secondary school, every student once a year. Thank you.
Thank you.
Okay, thank you very much for the presentation, and I see we have a speaker/question list starting, so I'll go to Councillor Volpatti.
Thank you, Chair, and thank you very much for the presentation. It's very interesting and I expect will be very useful in the future. That's the most important thing. So you found 80 students in this one population in a high school. So how many how many total students in that particular high school?
The number that completed the survey that day, I think, was about 350.
350. So slightly less than a quarter.
Yeah.
Okay. And did you screen for these survey questions? Were they able to screen for mental illness or the onset of mental illness? Through you, Chair.
So the survey itself doesn't directly screen for mental illness, but
I
there are
understand.
questions on resiliency and stress. But no
Do you
direct,
hear voices?
there's no direct questions on mental state.
Because that's a very telling question.
Mhm.
Do you hear voice? I would have expected that somehow would find its way into the survey question, but
Yeah, and so all this research is based on what the Australians themselves have researched, and the surveys were designed by them. So we actually didn't have any input into the actual questioning. What we did is we adapted it for language for a Canadian context.
okay. All right, thank you for that. And the part about personal safety was identified with family safety. Can you just explain that for a moment? Because I know it's an unusual finding. And
And so to be fair, this is something that we're relatively new. We're still considering what this actually means to the way we design program. But the finding that was surprising is that when we were speaking with the students themselves that answered that they didn't feel safe personally, what they were actually saying is that they didn't feel safe because their family in some way there's a trouble to the family. So either there was not enough food in the cupboard, someone might have lost a job, electricity had been disconnected, there were overdue bills. So it was really a threat to the family, not necessarily a threat to them personally, which is how we designed or how we anticipated the question would be answered is, do you feel safe at home? As in, do you feel that there's risk to you personally? But they interpret it as is there a risk to the family?
Right, okay.
Yeah.
And how, or did you ask questions about addictions? And what kind of answers did you get
Uh,
through you,
there's-
Chair?
Sorry.
You go ahead.
There were no direct questions on addiction.
So you had you have no finding as to whether any of these young people were experiencing problems with addictions?
Correct.
Okay, thank you.
Okay, thank you. Counselor Height.
Yes, you, the presenters, congratulations on this innovative approach. The next steps, and you've suggested going to the other board in another school. Screening obviously is critical to what you're doing, but let's forget screening. Are the school boards, and this is, I guess, directed to you, are you getting into the schools on a regular basis, all the schools, to make them aware of the agencies that are available to them, regardless of the specific screening? But I look at this being critical to make all the kids in grade 9 through 12 aware that there's a raft, mental health, etc. These agencies are available for their need if they need it. Leave the school, and here's how you get a hold of them. Is that being done?
Yes, I can speak to the District School Board of Niagara, because that's where obviously I
Yeah,
work.
that's
But
okay.
yes, absolutely. Our in-school student success team, which is comprised of our administration, our guidance counselors, our student success teachers, our co-op teachers, our special education teachers, social workers, and youth counselors, meet regularly, and they do have assemblies with the students on a regular basis, so that we share the information with the students on a regular basis, often at grade assemblies, in small group sessions. We have available the resources. We have a referral process to support in-risk and at-risk students. This was just the idea of this was another layer to add into what we already had in place.
I'm feeling better now. Thank you for that answer, because as we sit around here, we know how important education is, especially in their later years, because if they don't get that education, they don't get the higher income level, they might end up on our social system, and that's a cost to all of us forever. And that education is critical to them. So this is excellent. Later on, we have a report, and the mental health issue was brought up, but in a report later on today, or a consent item, they speak to, and I'll state, 1 in 5 experience mental health problems during a lifetime. That's scary. That's looking around this horseshoe of 30 people, and 6 of us are having an issue. And in the school, 1 in 5, 1 in 6 kids are having issues. So those are scary numbers, and I'm happy that you're being proactive. Thank you.
Okay, Counselor Beatty.
Thank you. Thank you for the presentation. Questions are somewhat related to the methodology. First of all, there was under the Harris years an attempt to have teachers follow a cohort of students through their school career. Did that succeed, or has that gone by the wayside?
Sorry, in terms of following cohort, in terms of mentoring, what kind of following the cohort?
Like a group of students would come in grade 9 and they would have that same contact teacher as a homeroom teacher throughout their career.
No, that doesn't exist in a formal process, but what we do have is we try to make sure that students, especially those in risk and at risk within a school population, are connected with a caring adult, which may be a member of our in-school student success team, could be a coach, could be a drama teacher, could be somebody else within the school, but we try to make sure that we're tracking individual students and supporting them and offering the supports they need.
Okay, I'm curious, that was one part of the methodology, because my experience was it didn't work too well when it was initiated at that point in time, so I wondered whether, I'm 14 years out of it, so I wasn't aware. The issue of the opting out is interesting. First of all, is this program considered a research program, and was it sanctioned by, like your board, I think does have a screening mechanism for approving research? Did it go through that process?
We did go through a process of referring to the senior team at our District School Board of Niagara, yes.
Okay. The signing out is an interesting concept, because I guess the issue I have is you don't have the certainty that all of the students would have taken material home to make the parents aware. And I'm curious, for the people who did sign out of that process, did you get feedback as to their rationale?
We did not. I'm not the administrator in that school where the pilot was. I'm a central administrator. I'm not sure if the principal of the school did connect with those individuals. They may have.
As I say, my only concerns were the issue of the methodology of that. So I could see some people having concern and finding out after the fact that they weren't informed to do the opt-out process. Might be problematic. So I just don't know what the communication mechanism was to the parents of those students.
Well, a letter went home to all of the students in the building to
okay.
explain, and the focus, again, as I said, was the full wraparound. We shifted the focus from just the survey tool to here's the supports that we have in our school to support your child.
Okay, and just a word of advice, if you're not already aware, the Conservation Authority has a St. John's Center with DSPN used to be involved in trips with elementary students, et cetera. It's now a First Nations program with the Scepter School Board, and they have given reports to us of significant positive impact of having those students in that rural location in the escarpment, et cetera, in another means of reaching out to students with special needs and so on. So if you're not aware of it, I'd recommend that you ask to go and take a visit.
Yeah, we are aware of it, and we have a similar program within the DSBN as well.
Okay, great, thanks.
Okay, so I don't see any further speakers. I just wanted to make a quick comment. When I was reviewing this presentation the other night, it reminded me I've attended Lakeshore Catholic High School graduation the last couple of years in Port Colborne, and the principal there always gives a really great commencement speech, and he's spoken both years of the number of students that go through that school, stay through the 4 years and graduate, who have come up against some of the, the worst odds that I don't think, a lot of us here in the room have experienced. And they either have been told to leave their home, or they have parents who are, hospitalized due to addiction, mental health, or they've lost both their parents, and they've still made it through the school system. And I know it's with the help of the faculty there, but it's so great to see that that you're working on these pilots and implementing these programs and giving them these resources to help. And I'm glad to see that the DSBN is involved, but also that they're negotiating a pilot with the Catholic School Board. So I just wanted to mention that because it was very inspiring. And if they have those supports, that those students can make it through and be successful. So on that note, I think Ms. Jugley wanted to respond to some of Councillor Volpatti's comments.
Can I just ask one
Sure.
more question? So you identify, through you, Chair, students at risk, not only with the survey, but with these changes in behavior, attendance or grade as well?
Mm-hmm.
So you're not relying totally on the survey?
No, absolutely.
Okay, thank you.
Thank you. Through you, Madam Chair. Just also maybe a little bit more context from the broader Australian model. So Australia is actually considered to be a lead not only in this kind of work, but also in early intervention, both in mental health and addictions. So when something like this is created, which is really an initial screen, it is mindful that it has the other models to respond. So I think that it's important to understand that it's not really meant to be an exhaustive assessment of all the things that could be troubling a young person. Also, the partners that have been involved in this project are aware of the early intervention resources that are available to young people. I think the greater challenge is really how much we can replicate that with this initiative, with the resources we have, and frankly, even some of our earlier intervention resources, which you'll probably hear about later. But Australia is probably one of the leads in early intervention for a number of areas. So I think it's a very good model, and I really appreciate our community partners presenting this today. Thank you.
Okay, thank you. So we'll move on to items for consideration, but I've been asked if we can just move 5.2 ahead of 5.1 because, so I guess I don't have to give an explanation necessarily. Councillor Volpatti, you'll move that. Do I have a seconder for that? Councillor Bentley. So I will call the question on amending the agenda to move that forward. All those in favor? And that is carried. So, so we will go to 5.2, which is the report, and it's the response to the provincial expert panel entitled Public Health Within an Integrated Health System. So does anybody have any, oh, sorry. Oh, yes, sorry. By all means, please do.
Good afternoon, Chair and committee members. Thanks for allowing me the opportunity. I wanted to take you through this report because I know you got it just as this morning. So I wanted to take it through. I apologize that it came walking on the committee floor. I know you're not very happy when these items happen. However, the task force did meet October 13th, just this Friday. I got tasked to prepare this report and present it to committee. So I did have good help. Dr. Yeager, it's odd for me to present this. Typically, this would be an initiative of Dr. Yeager. However, Dr. Yeager was instrumental in assisting the province in the development of the expert panel report. We were actually really happy that Dr. Yeager was involved, and thus, in order to prevent her to be in a conflict of interest, I'm presenting this report. I also had some really good help and consultation from Dr. Andrea Feller. Is she here? She's here and she's available for questions. And Sinead McAlone. There she is. And thanks for your help in preparing this report. So I want to give you briefly what the what the expert panel has proposed. The expert panel has proposed changes to the organizational structure where they're going to go from 36 public health units to 14 health units. The second is that these 14 health units would align along the same boundaries of the LHINs. Also, there'd be changes to governance, that there'd be 12 to 15 appointed members of a mix of municipal representatives, provincial appointees, citizens, and other members from education to LHIN in the social sector. So you see these type of boards. Police Services Board has a similar model. The Niagara Escarpment Commission has some models like this. So it's replicating some of the existing models, and there actually is some public health units that actually have this model. However, typically regional governments, the public health unit members are regional council as a whole. So those are the proposed changes at a very high level. And then we started receiving responses that the province has asked for responses by October 31st, and we're starting to see them come in. The one was the Association of Municipalities of Ontario, and they basically were straight out, and they said that they do not support the recommendations of the expert panel on public health and urges the minister and the provincial government to not adopt them. And then they put some rationale, which I've included in the report. The Region of Peel was the first regional entity that went early to their council, and so we did receive it, we considered it, and the Region of Peel has somewhat concerns with the expert panel reports. One of their concerns was the optimal geographical boundaries that support a system and service integration is warranted, and they're looking for more thought in how the boundaries are aligned. We also reviewed the Simcoe Muskoka District Health Unit, and they as a board felt that while it supports the goals of the expert panel to bring closer ties between healthcare and public health systems, the recommendations would not accomplish these goals. And they also talked about the cost of merging, and that may deter funding that should be going into programs and services. We also got a memo from the Council of Ontario Medical Officer of Health, and they commented public health governance must remain local, ensuring accountability to municipalities, the province, and the local population as a whole. And we just received, Dr. Feller sent me today a response from Alpha. Thank you, Dr. Feller. And that basically supports the concept of a local public health model. So the task force deliberated this on last Friday. They came up with 5 themes: the effectiveness of the current public health unit, the alignment of municipal jurisdictions compared to LHIN jurisdictions, the relationships with community agencies, the impact on regional governments and departments, and funding implications. I'll just highlight really quickly those 5 themes. So the first theme of effectiveness of the current Niagara Region Public Health Unit. Our public health unit is staffed with a very professional and dedicated team, and it's led by a very talented medical officer of health, Dr. Yeager. And it reports to a very accountable body, being regional counselors. If you look around this horseshoe, you will have lawyers, you have farmers, you have business people, you have engineers, you have professional planners, and other professionals and community advocates. You're a representative of your constituents, and it is a very cross representation of the communities you represent. We feel, the task force felt that that was the appropriate model. In the alignment with municipal jurisdictions and land boundaries, there's a concern that when you start expanding a public health unit, which incorporates in this model Haldeman, Norfolk, Brant, Hamilton, and part of Halton region, which is Burlington, that there are variations within municipalities and the social determinants of health. They could be very localized, and the thought is that, and the theme is that as you expand it, you start losing your focus on those local needs. Relationships with community agencies. Our current Niagara Region Public Health Unit has incredible relationships with local agencies that follow the same regional boundary. So, for example, police services, housing, and other United Way and other type scenarios. And also, they're able to respond to a local community need. And we look at an example of the opioid crisis that has come to our community. There's a quick assemblance of a committee, and we invited the public to join that committee. So it's very responsive on local community needs. Its impact on regional government. Dr. Yeager is also the administrator of EMS and emergency management. She's also a primary member on a corporate leadership team. And actually, when you're talking about planning issues and you talk about public transportations, Dr. Yeager is a valuable contributor to those discussions. So the public health unit is very embedded into our regional structure. And finally, funding implications. As Alpha, and we will circulate the document, has indicated, public health units have been asked to do more with no increase in funding. In fact, it actually went down about a half a percentage point compared to the previous fiscal year. Meanwhile, funding to acute care systems, the Ministry of Health has gone up about 3.6%. If you put more money in funding and more efforts into public health, perhaps we can deter some of the acute care problems and put pressures on our hospitals and our EMS system. So currently, it's a 75-25% funding formula where the province provides 75% funding and municipalities provide 25%. On average, our source is AMO. Municipalities contribute about 38% because the funding just simply hasn't been coming from the province. They've kept the froze on it. So you've made, as a Board of Health, you made the decision to put more money into the programs. So based on those 5 themes, the task force is recommending to this committee that you support AMO's position, and I would read it, that after careful consideration, do not support the recommendations of the expert panel on public health and urges the provincial government not to adopt them. And that's the recommendation before you.
Okay, thank you for that. So I see we have a speakers list, so I'll go to Councillor Volpatti.
Thank you very much, Chair. I was pleased to be on the task force that looked at this at our meeting on Friday. And I certainly agree with the endorsement, with AMO's endorsement, that we should support local public health, the model that we have presently. Although I would go even farther. I'd like to see the health boundaries aligned with the regional boundaries rather than the reverse, aligned with the LIN boundaries. But that's my own personal opinion. I endorse this totally. I think if not, we risk losing focus on local needs, and we risk losing our effectiveness on a board that is envisioned to be so much larger if it agrees with the LIN boundaries. I certainly think that the Association of Local Public Health Agencies reporting on the Council of Ontario Medical Officers of Health response. And just these couple of sentences I'd like to read from their report. Based on our many years of collective experience, the Council of Ontario Medical Officers of Health is of the opinion that implementing the expert panel recommendations would result in unprecedented change in Ontario's public health system. To use a medical analogy, we are not convinced that the expert panel focused on the correct diagnosis or that the recommended treatment is better than the disease. There will certainly be significant side effects. And those are from our provincial experts in public health. So my mind is made up. Thank you.
Okay, thank you for those comments. Councillor Rigby.
Thank you, Madam Chair. I move to defer this item to the next committee meeting, principally because we've just received this. We need some time to review it.
Councillor Rigby, just before we, it's October 31st is our deadline. I will get our CAO to speak to that, though.
Then I would suggest to the council meeting,
You would suggest?
moving it to, deferring it to the council meeting next week.
So not making a decision on it and just having it straight at council on October 26th?
Yeah.
Okay, so I need
Point of order.
It's,
Point of order. It goes there anyways.
okay.
Pardon?
It goes there anyways.
Madam Chair, it was a point of order that is allowed. The member
Do
can
you want to speak?
refer it directly to council without a recommendation from this committee, I think is what he's saying.
Yeah.
Carmen, did you want to speak to this in terms of the deadline and?
Recognizing your, through you, Chair, recognizing your procedure of no debate on a referral, I would just simply say it is correct. We have an October 31st deadline, and that it's scheduled as minutes of this committee. It will go to the October 26th meeting of council.
And the deadline's the 21st? So we're okay. I'm sorry, I'm not hearing what you're saying.
Through Chair to Councillor Rigby, you are correct, or sorry, it is correct that the deadline is October 31st.
Okay.
Um,
And our
By
next
the-
council meeting's before.
is October 26th, but minutes of this committee do go for ratification at council.
But we can also defer it to be discussed at that meeting, which gives us time.
Yeah. So that's, so you're still making that
Yes.
motion? So is there a seconder for that motion? Seconded by Councillor Marshall, so there's no further discussion or debate. So I'll call the question on deferring that to, okay.
The vote is open.
Okay, so then we will move on. So that is carried, and sorry, I was caught up in the moment. So now we'll move on to 5.1. So, yeah.
The results of the recorded vote were voting yes, Councillors Augustine, Bentley, DeAngela, Jeffs, Joyner, McGregor, Marshall, Rigby. Voting no, Councillors Beatty, Regional Chair Caslin, Diodati, Height, Maloney, Quirk, and Volpatti.
Okay, so we'll move forward then to 5.1. So I think, Ms. Jugley, you wanted to speak to that before we get started? Yeah. Yep. Yes, I see all the whispering, so yes, I was allowed to vote. I signed in just before we did it, and I went ahead and voted, so. Yeah. I didn't know if I should just address the elephant in the room or not. So, okay, Ms. Jugley. Oh, wait, sorry, let me get a mover and a seconder to get this report out on the floor. So moved by Councillor Quirk, seconded by Councillor Beatty, and now I'll hand it over to Adrian.
So through you, Madam Chair, as I believe most of the committee is aware, this is a good news story and was announced about a week or so ago. So we have received funding for the next 3 years through Home for Good, which is a funding program for supportive housing. And just for clarity for people, this is, if people are aware of Housing First, this is sort of Housing First intensified for very vulnerable, high-risk individuals that are high users of our shelter system, where we're providing additional supports in addition to case management, so mental health, addiction supports, and in this particular case, occupational therapy for people that are, for the majority of people that would be experiencing homelessness 6 months or more in a given year. So both, in this case, we have both operating or support dollars as well as capital funds that will allow us to build an additional 23 apartments specifically for this population. The request for you today is to receive this information, to consider approving one full-time equivalent staff to do the occupational therapy, which will be delivered in partnership through public health, and also to continue as we've done previously with Housing First procurement, where we reach out to the supportive housing or Housing First community with expressions of interest for both the support aspects of this program as well as the capital.
Okay, thank you. Chair Caslin.
Thank you, Madam Chair. First of all, I'd like to thank staff for their work in advocating for these dollars, in traveling to Queen's Park to meet with the Ministry of Housing to advocate for more dollars for homeless in Niagara, and also the councillors that participated in that advocacy at Queen's Park and at AMO. I think obviously it made sense for us to do that, and we see the benefit of that. I just want to be clear that to differentiate, one of our asks of the ministry was for additional CHIPPY funding because the formula that is used to distribute CHIPPY funding in the province is broken. And our ask of the province was to correct that formula such that Niagara got its fair share. Hamilton, on a per capita basis, gets much more than we do in Niagara, and we asked for that to be corrected. The response we got immediately was that would be hard to do in the immediate future, but there are other packages of money that we could apply for. This was one of those, and again, I want to thank staff for their efforts as well as those who were involved, because it's very meaningful for Niagara and will go a long way in helping us with our homelessness problem. Thank you.
Councillor Height.
Yes, through the staff. This is great news, but I do have a question. Because it's a 2-year funding or 3-year funding formula, sorry, thanks. And it looks like we're adding, it said 63 units for supportive housing, but you're hiring a new person, a new FTE, and I'm assuming it's out of the $5+ million. Is that not correct?
So through you, Madam Chair, it's actually out of the operating money, so the 1.8, which is over a three-year period. The majority of funding will actually go out to the community providers for case management and other supports that would be provided to the residents. The occupational therapist is in-house only because the community doesn't typically hire that discipline. Also, in part, this is also, we're receiving a lot of in-kind supports through our mental health program. I should highlight that, which has no additional cost to this. And so the occupational therapist is coming out of the mental health program and will provide additional connection to our ACT service, our telemedicine, our psychiatry telemedicine service, as well as early intervention as appropriate. So that it's, you can look at roughly about 750,000 per year is sort of the annualized operating amount. Obviously, we're mid-year for the first year, and then there's 2 years afterwards. Clearly, we're hoping that funding will then continue, but like Chippy, it's coming in sort of 3-year lumps.
Okay, you've clarified the 5+ million, 3.6 for capital, 1.8 for operating. Is this new employee, new FTE, a 3-year contract or 2.5-year contract? Or are we going to have an issue 2.5 years down the road when, if funding goes away, we now have a new FTE that we don't have funding for?
Through you, Madam Chair, to the councillor, and I will take that because the occupational therapy role largely sits within our community mental health piece. This is a reality that we face annually. So whether we have contract or not contract, we evaluate our budget every year, and in the context of 0%, whether that's coming from the LIN or from the Ministry of Child and Youth Services, we reduce our FTE as required. It's in the language of collective agreements that that's an understanding.
So obviously at 3 to staff at budget time, we see the numbers every year, new FTEs or minus FTEs.
Correct.
Good enough, thank you.
Councillor Volpatti.
Thank you, Chair. I echo the comments of Chair Caslin. This is really great news. My question through the staff, and I don't know who wants to answer this, but my sense is that there was a lot of competition for this money. So how were we successful?
Through you, Madam
And
Chair.
please just tell us all the good things you did, because I'm sure you did.
We can say, Carmen says we're awesome.
Yes, they are awesome.
I think that, frankly, I think it was a combination of continued advocacy or describing of local need. The ministry was well aware of the need, and I really thank council for continuing to highlight that need, both in visits to the ministry office and also in correspondence. I also would suggest that the proposal itself was unique and highly collaborative. We were aware that it was going to be a 3-ministry evaluation, which is unusual in the housing portfolio, and particular interest from health. And so, I mean, we didn't do it because of that, but we were aware that there was a real opportunity to highlight the benefits of a health component in this particular model, and a real openness from our mental health partners of actually adding more supports to this without adding additional resources. So the actual buying power for the people who will benefit from this is greater actually than the $5.4 million. So I think that those sort of in-kind contributions, local support, local advocacy, I think combined was very, very helpful.
And the collaboration, which was really, I think, key. So it must have made our application stand out from others. And I just want to congratulate staff again for coming up with this, for having it done in a timely fashion, so that because the timelines were very, what were the times like, Adrian? Let me ask that.
Through you, Madam Chair, the timelines were literally weeks.
Right.
And so for a proposal of this size, with the expectation of local collaboration, the timelines were extremely tight.
Right. So once again, congratulations to staff and a job really well done. Thank you.
Okay, thank you for those. Councillor Augustine.
Thanks very much, Madam Chair. Sorry, I just got in there. Do we know, is this, again, congratulations to all involved. It's a great thing. Are there additional dollars available in future years? Do we know that, or is this a one-off, or?
Through the chair, just in terms of additional funding to this type of initiative?
Exactly, yeah, this is for 40 units plus 23. I'm just thinking of other opportunities there might be in Niagara.
I'm not aware of anything coming in the supportive housing portfolio.
Okay.
We are keeping an eye to the national housing strategy and funding changes that may happen with the federal funding, including funding that's associated with homelessness services. And we anticipate that there will be more information about that in November on the National Housing Day. So that's a piece that we're keeping an eye on. In terms of provincial homelessness money, I'm not hearing anything additionally at this time.
Okay, thanks.
Okay, seeing no further speakers, then I will call the question. All those in favor? Opposed, if any, and that is carried. So now we're moving on to consent items, and I am going to go through those individually because we do have a presentation with one of them. So we're at 6.1 PhD 16. So I need a mover and a seconder for that. So moved by Councillor Volpatti, seconded by Councillor Augustine. Were there any questions or discussion related?
Looks like great work.
Okay. Councillor Volpatti?
Once again, great work. I mean, I think it's just, we have to somehow boost the medical attention that we're getting with this kind of attention to people with serious mental illness, and we have to catch it when we can. So thank you.
Okay, thank you. So then I will call the question. All those in favor? Opposed, if any, and that is carried. So now we're on to 6.2 MOH 03-2017, and I will look to Dr. Yeager then to. Yeah, that's great. So Dr. Yeager is just going to make her way over to the podium.
Public health. And thank you, whoever just turned the microphone on. So program budgeting and marginal analysis in public health has been described as zero-based budgeting in a highly regulated environment. And so we will come to that in a minute, but I want to provide a little bit of background as to why we embarked on this process. You have before you what we fondly term our Niagara Region Public Health Priorities Matrix. As part of Regional Council, our strategic plan is the strategic plan of, the 4-year strategic plan for Council, but nonetheless, it was felt that it was of use in the specific context of public health to have something to focus our thoughts and extra attention. It is a very simple document. This is a one-page plan. This is it. There are no appendices, references, or extra pieces, and so it is designed to be fluid. Along the bottom, you see the words prenatal, infants, children, youth, adults, and older adults, and that relates to our life course approach, which we have brought before Council in the past. Dead center of our lotus is health equity. And this is a focus currently from the province and also is at the heart of public health. I believe that we are aiming for not just health in our population, but health equity across the members in our population. So our overarching statement is that we need to have impact on health and health equity through resonance with the people of Niagara. And we have 4 quadrants: what we will do, how we will do it, the resources we will need, and skills that we will need. What we will do by no means is a list of everything that public health does. We have Board of Health, Regional Council Board of Health is responsible for the administration of approximately 46 different programs in public health, and they are, of course, not listed there. The successful accomplishment of them is reflected in our accountability agreements to a certain extent. The number 1 there is Niagara's top 10, and that is the large data report that we put before Council in terms of major reasons for EMS transport, admission to hospital, presenting at an emergency department, and that kind of thing. The LHIN Patients First refers to our renewed responsibility in informing the LHIN on the needs in population health assessment, and our greater responsibility and actually great pleasure of increasing our connection with primary care on many levels. Integrated health outreach refers to the innovative work being done by our community medicine section under the leadership of Chief Smith, but also some direct nursing outreach, social determinants of health nursing pieces that we have, and a role called a community health broker. Reflecting in the life course, I have just listed two major overarching departmental-wide objectives that we have set ourselves, and they are still in initial phases, and we will bring more to council when we have more to say. One on mental health and one on parenting strategy. Under how we will do it, there's various skills, resources we will need. I mean, basically, we are a person organization, so we need people and money. And that's sort of pretty much it. We don't need a lot of machinery. We really don't. So fresh air is always nice. But in terms of the resources, I want to highlight now, in terms of the dollars, the program budgeting and marginal analysis. So why did we do this, and what problems were we trying to solve? So my dad was a mathematician and an engineer, and he said, you know, if you really want to be doing something, Val, only person I ever let call me Val, you need to accomplish three things, right? It's not good enough just to do one thing. You should be aiming to solve preferably about three problems at the same time. So public health is facing at least 3 years of 0% provincial increase, and we have been told to expect that to continue. And I want to get to the second point of maintain cost-shared balance. So we heard in this CAO's excellent presentation in terms of AMO's comment about a 38% contribution from average from municipalities. That is an average from regional and large municipalities. The majority of boards in Ontario are independent boards, and they are obligate. They get a bill for 25%, and that's it. I want to assure council, and in a sense reassure council, that I have maintained your levy contribution at 25% on the cost-shared programs. Our cost-shared budget is 26.5 million. Our levy contribution this year, 6.61 million. 25% would be 6.62. We'll let the $10,000 go. We get it back in other ways. But this is important in the context of 0% provincial increase, because if we are going to maintain the cost shared balance, and even if guidance is 1.5%, right, it's not fair in a sense for me to continue to ask council for 1.5%. And not only that, when we sit around the CLT table, that 1.5% is an overall guidance, and it's actually a very good collaborative, discussive process with your commissioners as to where that should best go. And as a public health professional, I cannot stand before you and say that I don't want good roads, right? And I don't want safe water, and I don't want the Commissioner of Social Services to have money to work with. So it really is working together in that context. We also wanted to respond to this new Niagara's Greatest Needs, our Niagara Top 10. How are we going to do that? And starting in 2018, we have a new standards for public health, which we will be responsible for setting. So I'd like to describe to you this process. It is almost an RFP for your budget. We used something called prioritized software, and the software is a tool, and PBMA itself is a budgeting tool. You can use it if you have a windfall of money. How should we best spend it? You can use it if, my goodness, all of a sudden, like, we've lost 20% of our budget. What are we going to do? Or you can use it to maintain zero. But it is a process of strategically allocating money on your greatest needs, as opposed to just everybody gets the same across the board, which presupposes that everything you did before was more justified than everything you might do from now on. So there is a process of the priority setting framework, which involves, and this was basically a process which was undergone by our senior management team. That was our priority setting committee. So the first thing we did was set out, in a sense, what is our matrix? And then these things were all weighted, and how much weighting are we going to apply to health impact, connection resonance to the people of Niagara, determinants of health, client experience, legislative requirements and provincial mandates, organizational capacity, workplace environment, fostering of innovation, collaboration and partnership, and an assessment of implementation challenges. The process is a process of disinvestment and then reinvestment, and you're not allowed to tie one to the other. Risk criteria, I will just go into before I go into the actual process. What might our risks be? Unexpected financial, ongoing operations, political, health equity and impact, and reputational risk were things we considered. So as a senior management team, we sat around and discussed these things and gave them different weightings, so that at the end of the day, projects that people came up with got put into the prioritized software and a number came out. So it wasn't, you had to be fairly rigorous in your assessment, and then of course at the end of the day it was a bit of a debate as how one got to any particular number. So what were the challenges we were facing? If we did nothing, in order to keep us at zero, our 2018 budget pressure was approximately $581,000. I asked my staff, if you needed to respond to the standards, how much money would you need? How many positions would you need? And let me know what they were. And that came up to about $900,000. I didn't want them to apply a financial lens on that, just what would you need if we did nothing? So that comes to about close to $1.5 million. The person who was leading us through this is a healthcare economist person out of Vancouver. He said on your base budget, that is a lot, 1.5 million to try and find. It would be over 5%. And so he suggested a target of 1.2 million. So the direction to our senior staff, who I must say were absolutely phenomenal, and the degree of collaboration at all levels throughout public health was more than I could ever have hoped for, but I should know by now. So the disinvestment target was 1.2 million. And people were only going to get back 579,000. So you're sent out, everybody got allocated part of that 1.2 million based on their pre-existing budgets. So if you had a bigger budget, you had to find more, and if you had a smaller budget, you didn't have to find quite so much. We got back 1.152, so we didn't quite get there. So because we didn't get more disinvestments than we asked for, we didn't really have to choose between them. We accepted all the disinvestment proposals. The resources available for reinvestment were $579,000, and not surprisingly, the requests that were received were of the order of $1 million. So then that began what I found was truly a wonderful process of looking at all these pieces and saying, you know, this is almost the same as that. If we got together, could that be one person? And usually the answer was yes. Or I've got somebody that's doing a little bit of that already. If I expand that 0.2 to 0.4, can you take off that half an FTE and so on and so forth? And we got down to about $700,000 and we were all exhausted. So I said, okay, that's enough. We'll come back in 4 days and we'll get right back at it. And by the time people came back, there'd been this horse trading behind the scenes. I'll give up this, or this is what I really want. And at the end of the day, we got down to the $579,000. So before I forget, I do want to say that we did save, or 10.9 FTEs came down. But those are real people who had real jobs, and I do want to acknowledge that in a sense, in terms of difficulty, those are the people who have experienced the greatest direct difficulty from this. And so I acknowledge it's not a question of numbers and paper, there are real people here. And also how difficult it was for the managers in that situation. But at the end of the day, we were able to do things that we would never have been able to do in a transformational piece. And the other transformational piece is I think that we will never again work the same way in our divisions because we automatically think much more cross-functionally. So we now have a health equity coordinator. We have much better support for data entry and analytics. We have a new position in mental health promotion. We have developed a rapid response infection prevention and control SWAT team across 2 of our divisions. We have increased our outreach nursing in sexual health, so going more directly to where the very high needs clients are instead of expecting people as much to come into our clinics. And we are working on something which is called the Nurse Family Partnership, which has been studied to have the greatest impact in the lives of most vulnerable kids from a societal standpoint and have the greatest impact on completing education, non-entry into the judicial system, and not ending up addicted in the long run. So that is why we did it. It was an awful lot of work. I think we're okay for next year, so we don't have to have to do it right away. So it has pluses and, as I say, the minuses are set not by the process. The minuses are set by you have to maintain zero, so you're automatically at a $590,000 deficit position. Thank you. I'd be happy to answer questions.
Okay, thank you very much for the presentation. I have Councillor Augustine.
Thanks very much, Madam Chair, and thank you, Dr. Yeager, for explaining that process to us, and thanks to you and your staff for doing that process. It sounds to me like, you know, essentially it's better service, more focused delivery, focused on, it's kind of a tune-up in a sense, but also it's not only that, it's a rebalancing and refocusing of what you're doing, but with the same dollar level and then just adding sort of a little bit. So kudos to your staff for having that conversation. That must have been a hard conversation, and in many respects an adult conversation, if I can say that, in the sense of you know, no sacred cows sort of thing, or the elephants in the room, as the chair spoke about earlier. How did that, maybe we can just hear a little bit about that. I'm assuming that, so you'd probably phrase it in a much better way. How did those conversations happen? Is just a common level of respect across the entire public health service?
So through you, Madam Chair, certainly that must exist, and I'm not certain I have all the answers, and I'm not trying to evade the question. I think it would have been impossible if we hadn't done the data work ahead of time, which said, this is what we need to focus, and the data tells us that. So we had that piece. We also had the requirement to respond to the standards. We have a whole new requirement on annual business plan reporting, so that was one thing. But we do have some staff, one member of staff, who had done this in another health unit, and she said her experience there was totally different. It was acrimonious. People were, I'm not saying undercutting, but it was not a friendly process. Something happened which I didn't expect, and I didn't think it was okay, and people started looking over each other's walls and said, well, you know, that job there, I'm not certain that's particularly useful. Or maybe you could do it another way. And my initial reaction was, how rude. But my directors are obviously much more, I don't know what you're getting at, than I was. And they said, no, we need to hear that. And sometimes it's helpful if people point out things that aren't quite that way. So I know, does that kind of get
that helps, and it sounds like sort of the egos, the megos, the kingdoms, the fiefdoms were all wiped out and said, look, we're in this together. Let's talk about this and let's figure this out. And so again, you know, congratulations to you, Dr. Yeager, and to your staff for having those conversations. Those are hard conversations to have. And especially if you're saying in another situation, it was acrimonious. They didn't have that perhaps level of trust or respect or, you know, that's absolutely huge, Madam Chair. And so again, congratulations to staff for having that discussion.
So speaking of who you couldn't do without, we had huge support from finance in our personal PFA, who is Terry, who is not currently with us, but I don't know how many times she ran the numbers, because you have to run the numbers, and the position you're replacing is in a different category, and also HR, Irene, I think is not here, but our HR consultant. So our support from finance and HR was phenomenal.
That's great, thank you.
Total cost $25,000, but if anybody else in the corporation wants to do it, my understanding is it's only $8,000. We can repeat this annually for very little investment.
That's great, thank you. And that was my question, sort of maybe offline or in an email, the doctor could share who the group was that did it. It's an intriguing process, and I'm sure the CAO is also considering, are there other units, departments in the corporation where this can be followed? And then the final is, and I hate to ask this because I don't want to minimize the work that you've done, but the doctor spoke about it, Madam Chair. you said we're okay for next year. So, this retuning or reprioritization, how often would that happen? It's not an annual thing, it sounds like. Is it a 3 or 4 years or 5 years? Or maybe you don't have an answer to that, but I guess this isn't something that you can kind of, I'm understanding by the comment, it's not something you can do every year. So can we just hear just a little bit more about that from Dr. Yeager?
Yeah, I'm not certain it's a process that lends itself to, we just need to tweak a little bit, right? On the other hand, I think we need to be partly informed by the data. If we get something that happens in the year and says that we really need this position, we might have to, because we don't actually have that position. We don't actually have those dollars, so we would have to find them. But sort of all things being equal, I think probably every 5 years is too long and every year is too soon, and I don't know that I can be much closer than
That's
that.
fair. Thank you very much. Congratulations.
Carmen would like to speak to this.
Through you, Chair, to committee, Dr. Yeager and her team did present to the corporate leadership team. She presented this presentation. It was well received, and we had a favorable response of other department heads who are looking at it to see if they can replicate it within their own departments.
Councillor Volpatti.
Thank you, Chair, and I look forward to that, because when you say zero-based budgeting, it's like, a curtain has
I've never heard you say that before.
a curtain of terror has been drawn around everything. And I have to say, because Dr. Yeager alluded to this, when she first approached the microphone, very good things come in very small packages. Sorry. I had to say it. And also, as far as to all other departments, I mean, the whole process is paradigmatic for all departments. And I like particularly whatever screen it was that brought forward all kinds of eventualities that we could face in any year, and that this process really took all of that into account, just by the way it's laid out. So I think it's a great way to begin to introduce the ZBP across the region. Thank you.
Okay, Councillor Height.
Yes, great process. I'm intrigued that we heard from our CEO that if, and it's not when, because it looks like this should go in every department to review from looking outside the box in a sense. Let's lay all the cards on the table and review everything we're doing today and see if we can do it better and with different people in different positions. This should be done on a regular basis, and I hope the other departments take lead by you, and maybe you can help them save some money, because obviously we're looking at the budget and we're trying to keep it lower, and there's great demands all over. And in a sense, it's unfair, I'm thinking, for your department, because if you're really saving the region a lot of money, then some of the other departments can sort of take it easy and use your, and I know they aren't, but use your 1.5 or 2% that you could have got. So thank you very much.
Okay, thank you so much for the presentation, Dr. Yeager. Now I need a mover and a seconder for the report. So moved by Councillor Volpatti, seconded by Councillor Bentley. Any further discussion? Seeing none, then I'll call the question. All those in favor? Opposed, if any, and that is carried. So now we are on to 6.3. So I'll need a mover and seconder to get that on the floor. Moved by Councillor Rigby, seconded by Councillor D'Angela. Any questions or comments on this one? Councillor Rigby.
Well, thank you, Madam Chair. I just wanted to move that, and because this will be, I was on that board for a very short period of time, as we all know, but it was during that quarter, so I'm very pleased to see the report, and we're moving forward. Thank you.
Okay. Okay, so seeing no further questions or comments, then I'll call the question. All those in favor, and that's carried. And now we're on to the last one, 6.4. So I'll need a mover and seconder for that. moved by Councillor Height and seconded by Councillor Augustine. Any questions or discussion on this one? Okay, I will call the question. All those in favor? And that is carried. So now we are on to other business. Councillor Augustine?
Thanks very much, Madam Chair. I did, I think, send this to you and to, or to Councillor Joyner and to staff. Just, I've been hearing from interactions with folks at Woodlands of Sunset that there's some interest in some sort of trail system in and around the property. So I'm just hoping that at a future meeting, staff can give us an update on that, an information report.
Okay, they're nodding yes, so.
Great, thank you.
All right, thank you. Any other business from any other people? Councillor D'Angela?
Madam Chair, just asking the other members on the committee, does anyone else have troubles with their computers? Because I haven't been able to get any reports at all while we're at this meeting. So I'm just wondering if it's just my computer or if other people are experiencing some technical difficulties. It's a little frustrating, but I'm just wondering if it's just me.
So are these the reports like in the e-scribe? You're having a hard time accessing them?
Yes.
Okay.
Yes. I haven't seen any of them today.
Okay, and that's happened to you in the past?
Well, it seems to be a consistent pattern where there's been some difficulties, but it's usually just when I'm in this council chamber. That's why I'm wondering if it's just my computer or if it's others.
Because I would suggest reaching out to IT
yeah,
on that, yeah.
yeah.
But,
Chair,
I definitely
IT's
will.
right up there. You just got to go in the room. They'll fix it right away.
okay, so any other business? All right, seeing none, our next meeting is November 7th at 1 p.m. So this meeting is adjourned.